Hi everyone, today we'll be talking about the respiratory short case in the PACES exam. This is an outline of the content we'll be covering. We're talking about the types of cases, an approach that you could adopt, some examination tips, presentation, investigations, management, and details about specific conditions. So let's begin with the types of cases. In my opinion, for the respiratory short case, there are three conditions that predominate this station, and that's interstitial lung disease, bronchiectasis, pneumonectomy, and lobectomies. There are some other conditions that can come up, but these are much rarer, and they are listed below here. So the approach that I take is somewhat a simplistic one, based on what comes up commonly, but at the same time when you prepare, it's important to also ensure that you have an adequate safety net in your approach to not miss and be able to handle some of the rarer conditions. But by and large, because of the high prevalence of the aforementioned three conditions, the very first thing I look out for is the presence of a scar, and I would very deliberately hunt for the presence of one, sitting the patient up, inspecting over the posterior aspect carefully, and looking carefully along the ribs, as some of these lateral thoracotomy scars could be very well healed. If there is a lateral thoracotomy scar, then I would place my money on it being a likely either pneumonectomy or lobectomy, and I would then pay very close attention to the position of the trachea and the apex beat. If there isn't a scar, then I would be thinking most likely ILD or bronchiectasis or some other condition, and I would look out very carefully for crepitations and aim to characterize the nature of crepitations. So these are some general examination tips. So like as mentioned, it's important to hunt for the scar, and some scars can be very well healed and very faint, and if you don't look for it, you might not see it. Next would be to look out for any autoimmune stigmata. This can be found in the face, for things like for features of systemic sclerosis or heliotrope rash in the instance of dermatomyositis. The hands is also a good place to look out for features of psoriasis, rheumatoid arthritis, and the overall posturing of the patient may cue you into ankylosing spondylitis. It's also important to observe for the presence of any RT marks, as that can be a cause of interstitial lung disease. Next, also, when you inspect from the foot of the bed and the patient inspires, it's very important to examine and look for symmetry. You want to know whether it's a symmetrical or asymmetrical disease, and you would then be able to pay appropriate attention to the area that is that is moving less. It is important to consider dextrocardia, especially in a patient with features of bronchiectasis, as Carter-Jenyns syndrome is a condition that can come out in the PACES respiratory short case. So while oftentimes the apex beat may not be the most prominent, it is important, if you don't feel it, to actually check the other side. One tip that I find slightly useful is that if I'm unable to feel for the apex beat, sometimes I attempt to auscultate for heart sounds, and if it's more prominent on the right side, that may cue me into the presence of dextrocardia. If there isn't a scar, the money is oftentimes at the back, so you need to ration your time wisely, because the respiratory examination can be quite time consuming, and you need to ensure you have adequate time to auscultate adequately at the back. So then comes your presentation. I always try to inculcate a discipline to end off with a wish list, by saying that I'd like to complete my examination by reviewing the patient's temperature chart, performing a bedside pulse oximetry, examining the contents of the patient's sputum mark, and taking a drug and occupational history, especially if you're suspecting interstitial lung disease. If you're confident, you can state the diagnosis up front, followed by evidencing by the cardinal features of that diagnosis. I then go on to always talk about chest expansion, percussion, breath sounds, and vocal resonance in a methodical fashion, and then commenting what apex beat and trachea, regardless of the condition. Then I talk about complications and etiology, with complications being that of cor pulmonale, polycythemia, pulmonary hypertension, respiratory failure, and respiratory distress, with the mnemonic of CPPRR. And then I go on to talk about possible etiological differentials. Investigations generally we always begin with a plain chest radiograph, followed by imaging-wise high-resolution computed tomography. If you are looking for parenchymal disease, like let's say interstitial lung disease or bronchiectasis, If for some reason you're looking for masses, or let's say to evaluate a infusion, then you may not want a high resolution computed tomography and opt for a CT thorax instead. Next will be a pulmonary function test. And if there's an indication, so there are more invasive procedures such as a bronchoscopy, as well as percutaneous biopsy. So this is an overview of management of a pulmonary condition, mainly more for ILD and bronchiectasis. So it's multidisciplinary, involving the respiratory physician, allied health staff, and patient education. General measures include smoking cessation, vaccination, chest physio, symptomatic relief, treatment of infective exacerbations, antibiotics, and treatment of underlying disease. LTOT have the following recommendations as stated in the slides here, and you can always consider surgery in the form of a pneumo or lobectomy if there are complications, and lung transplant. So this provides the full spectrum of management from non-pharmacological general measures to invasive surgery. So we talk about interstitial lung disease. In terms of clinical findings, the main features are find and inspiratory palpitations that do not change with coughing. Oftentimes patients will have an associated dry cough, and there may or may not be clubbing. Causes-wise can be classified into idiopathic and secondary causes. For secondary causes, the big groups are autoimmune rheumatological disorders, occupational, and drugs, or iatrogenic if you include radiotherapy. The causes are listed below. Another way of classifying is based on whether it's predominantly apical and basal. The way I remember it is that for most autoimmune causes are actually basal, with the exception of mainly ankylosing spondylitis. Psoriasis, if I'm not wrong, can go either way. Most pneumoconiosis or occupational exposures tend to be apical, and the way I remember it is because when you breathe something in, it affects the apex more, with the exception of asbestosis. And drug-induced causes tend to be more basal as well. Yep, so this is how I remember the apical and basal distribution. This slide is not intended to be memorized, but the idea is that sometimes when one studies the ILDs, one tends to get lost amidst the nomenclature when one starts talking about things like UIP, IPF, NSIP, and things like that. I think for the exam, it is probably advisable to avoid going down a discussion in that vein, unless one is very confident about the terminology. But I think the important concept to bear in mind is that when it comes to interstitial lung disease, there is a histological, a clinical as well. There's histological and radiological and pathological features to it that one needs to be aware of. So let's say we talk about the UIP pattern. So UIP pattern is usually commented based on radiological features, and if one does a biopsy, there are supportive histology features as well. And there is an idiopathic variant of it, which should be called IPF, but there are secondary causes such as CTDs, drugs, asbestosis that can also give you a UIP radiological or histological diagnosis. And likewise with the NSIP pattern, you can get idiopathic NSIP, or you can get secondary causes that result in an NSIP histological or radiological pattern. Okay, so but I think the bottom line is try to avoid getting into such discussions in the context of the exam. So in terms of investigation-wise, for plain chest radiograph, you can look for reticular nodular shadowing. HRCT, it depends on the type of ILD as described in the previous slide, but some of the features include ground glass, honeycombing that you can look out for. Generally, you get a restrictive picture. This is evidenced by a preserved FEV1 over FVC with reduced FVC TLC, and there's also reduced transfer factor when it is due to interstitial lung disease, because it is a restrictive intraparenchymal disease. So lung biopsy is sometimes indicated, and there can be further tests done for etiological evaluation. In terms of complications, an echocardiogram can be done to look for pulmonary hypertension. And specific treatment include the general treatment measures mentioned earlier, stopping of offending agent if it's due to drugs or occupational exposure, immunosuppression in autoimmune disease, and one can consider antifibrotics or tyrosine kinase inhibitors in the context of idiopathic pulmonary fibrosis. This is something that might be asked in the exam, so it might be good to just know. Bronchiectasis, the features are coarse, pan or early inspiratory crepitations that change on coughing. They may not clear, but there is a change in the quality. Classically, they often have a chesty cough, there may be clubbing, and also remember to check for dextrocardia in the instance of cardiagenesis. For causes-wise, you can think of it in terms of congenital and acquired. Congenital includes cystic fibrosis, cardiagenesis, or basically the group of primary ciliary dyskinesias, and hypogammaglobulinemia. Acquired causes can be classified into focal or diffused, and for focal causes can be extraluminal, luminal, intraluminal, and for diffuse causes, they are stated below. Investigations-wise, for plain chest radiograph, one can visualize trem tracts and ring shadows. HRCT demonstrates signet ring sign, dilated bronchi. Pulmonary function test oftentimes is an obstructive picture, although it depends on where on the spectrum of bronchiectasis the patient is at. And etiological investigations include evaluating for specific conditions such as ciliary motility, dyskinesias, genetic testing, sweat tests in the context of cystic fibrosis. Treatment-wise, as mentioned, general measures, bronchodilators, treating the underlying cause, and sometimes consideration of macrolide-based therapy or inhaled antibiotics in recalcitrant recurrent infections. Complications-wise include recurrent infections, hemoptysis, empyema, and disseminated infections. So next we talk about the pneumonex and the Lobecs, and this is something that I find quite interesting. So when we see a scar, then the next task is to determine whether this is a pneumonectomy and lobectomy, and hence I would then pay very close attention to the position of the trachea. If the trachea is deviated to the side of the disease, I would then attempt to determine, I would say that this is most likely an upper lobectomy or pneumonectomy, and then I'll be looking out for the presence of breath sounds. So in general, a lobectomy, you would actually hear classically quite a fair amount of breath sounds because when the lobe is removed, the rest of the space actually gets filled up. It doesn't become an empty vacuum. But in the case of a pneumonectomy, then you would actually classically notice paucity of breath sounds over the affected area, except at the top where you can sometimes hear bronchial breathing. But what I have come to notice is actually this is oftentimes a spectrum depending on how close or how far away you are from the pneumonectomy or lobectomy, how the healing has taken place. So I think it's important to recognize hard signs, softer signs, the presence of signs and the absence of signs and what it says. So if the trachea is deviated, I would say yes, it's most likely a pneumonectomy or upper lobectomy. But if the trachea is not deviated, then I would say that it could still be either a pneumonex, an upper lobect, or a lower lobectomy. Yeah, and in terms of for the lobectomy, sometimes also you do notice a decrease in breath sounds over the affected area. Sometimes the breath sounds are completely normal. And likewise with the percussion notes and the vocal resonance. So I think it's important to take things in its totality rather than basing things on a single sign. I would say a deviated trachea to the affected side is a hard sign, but in terms of things like whether or not there's a relative decrement in the breath sounds, whether it's slightly duller, I would be cautious to base things on a single sign and take a step back and look at things in its general totality. Causes for pneumonic and Lobec will include mitosis or suspected mitosis, abscess, bronchiectasis, TB in the past, lung volume reduction surgery, and surgery for trauma. This slide summarizes the clinical features that distinguish collapses, consolidations, effusions, and fibrothoraces. I'll leave it to you to read and to conceptualize it in your mind. And this slide just talks about pleural effusions, where the Lights criteria is something that we are familiar with. These are the tests that we send off. We can classify them based on microscopic evaluation, microbiology, and biochem. And in terms of causes, classify them based on transudative or exudative. So I would say for the respiratory short case, number one, hunting for the scar is very important. Number two, I will put my money on ILD, bronchiectasis, and pneumonic or lobectomies. And in terms of distinguishing the types of lobec pneumonectomies, it's important to have a very systematic thought process, being able to weigh the signs that you have picked up, putting them together and coming up with basically committing to one of the above diagnosis. So I hope that you found the session helpful, and all the best.